Ji, Assalamu alaikum. Uh, it's an absolute pleasure to be invited to provide a brief overview regarding giant cell arteritis. So I'm sure most of you guys would know me. So I work in Fatima Memorial Hospital. So just a brief little bit about where my affection as regard giant cell arteritis started from. While I was in Dublin doing just rather prior to my PhD, and then of course further on when I was doing my PhD, so we used to run dedicated rapid access giant cell arteritis services, and also we used to do dedicated vasculitis clinics where we used to see these giant cell arteritis patients. And so we used to share a significant number of patients. So that's why I had this sort of, you might say, a bit of affection, bit of like interest, if you like, in giant cell arteritis. So without any delay, we'll just move on to providing a little bit of brief overview as regards GCA, as I'm told that I've got only about 20 minutes plus minus. So we know that giant cell arteritis is the most common primary systemic vasculitis, and we know that it is a large to medium vessel vasculitis, which predominantly affects second to fifth order branches of aorta, and most commonly in the extracranial arteries of the head. It's been told, and we have been studying this all day long, that it is more common in the Northern Europe, and it's always been discussed or suggested, or you can say, considered that it is very uncommon to be in Asians and Arabs. I'm not sure about this because I used to think the same, but in last 2.5 years of working in Pakistan, I have got well more than a dozen of patients that I have come across in my clinics. So I don't think that it is that uncommon, but very commonly, I think that it is very much under-recognized, if you like, and I have absolutely no doubt about it. We know that it is a little bit more common in the female compared to the male, and with the lifetime risk, if you like, is 1% in the female and 0.5% in the males. Now, if you look at the percentage of the clinical or the frequency of the clinical features overall during the disease course of giant cell arteritis, we can see that the headache, the polymyalgia rheumatica stays on the top, that up to 70 to 90% of the patients with GCA are going to have some form of headache during their disease course, and it's the same as regards polymyalgia rheumatica of around 60%. However, it's very interesting to know if you look at the column on the extreme right, which shows that only 1/3 of the patients of the GCA are going to have headache as their initial manifestation or the initial presentation, if you like. So in other words, there's a significant majority of the patients are going to have some other clinical symptoms as a first initial presentation for giant cell arteritis. So in other words, we should not only be focusing on headache, but there could be a lot of other clinical manifestations of giant cell arteritis. So we know about the giant cell arteritis is a granulomatous inflammation, and all three layers of the vessel wall can be affected, but more so is the intima and the media. And later in the disease course, there is so much intimal hyperplasia that there's a complete blockage of the vessel wall. And that is the time when we tend to see the occlusion of the arteries and the consequent ischemic complication, for example, the vision loss or the strokes. So this is a little bit of how the disease would progress, if you like. So this has been to date the gold standard when we diagnose giant cell arteritis. And as you can see, this is a very simple, very sort of classification criteria. It's the age of the disease of onset, the new onset of the localized headache. And that is very important to know. It's not just asking about the headache, but asking about, is this a different type of headache? Is this the usual headache that somebody or most of us going to have at a certain time? So it's a new onset of the headache, and of course the temporal artery abnormality, and the most significant or the most specific one that we should be looking for is the temporal artery tenderness and the reduced pulsations. And of course, naturally, there's going to be elevated ESRs and the positive temporal artery biopsy. And there are certain features in the biopsy which are more suggestive of giant cell arteritis. For example, the mononuclear cell infiltrates, the granuloma, for example, finding there, and the evidence of the giant cell. And if you look at only 3 out of 5 of them are present, that the sensitivity and specificity is more than 90%, which is quite remarkable. However, the problem and the diagnostic dilemma are the real sort of the challenge in dealing with these giant cell arteritis patient is also the same as we just discussed in the last slide, which is the diagnostic sort of our classification criteria, in which there are a lot of, for example, the non-specific features. We are dealing already with the elderly population. They're non-specific, for example, the headache and so on. So there is always a risk, for example, that we can easily miss the giant cell arteritis, and the consequences, of course, we should not be forgetting is the dreaded complication is the blindness and of course is the stroke. But having said that, at the same time, we should be very much be concerned about over-diagnosing them at the same time because these symptoms are quite non-specific. And of course, if somebody is going to have some form of even in infectious etiology or upper respiratory symptoms and so on, the people are going to have new onset of course, the symptoms in their head and neck region, raised ESR and CRP. Of course, in somebody is already elderly, so the unnecessarily sort of anxiety of the giant cell arteritis can be we can easily face. So we should be very much cautious not to overdiagnose because the morbidity of overdiagnosing, because you're talking about the elderly population and you're talking about at the same time high dose of steroids, and that again for a number of years. So that's why the consequences of steroid toxicity, we should always be keeping this in mind. The clinical presentation. So if we can make our life easy in simple words by if we can think of those three categories. One is the cranial symptoms only. The other one is the cranial ischemic objective signs or the features. And the third one is the extracranial. For example, now we are talking about the symptoms, cranial symptoms, for example, the headache, the jaw claudication, scalp tenderness, for example, the systemic symptoms, the malaise and so on, and the temperature and the polymyalgia rheumatica. So these are the cranial symptoms. Then comes the cranial ischemic objectives, sort of the features, for example, loss of vision and the stroke. And then the third one we should be also be considering of the extra cranial manifestation, for example, large cell vasculitis, the upper limb or lower limb, for example, the claudication symptoms and so on. So it will, if you can think of these three subcategories, then of course the management and further the follow-up will become a little bit easier, I believe. So the initial workup is very standard, very simple. Of course, we need to look at the acute phase reactants. We also need to be doing the basic workup, the creatinine and the liver functions, of course. The urine, of course, we need to be doing also because we are talking about some form of systemic vasculitis. And the temporal artery biopsy, of course, is we should always be trying and achieving that we can get the temporal artery biopsy because the tissue remains the cornerstone in diagnosing these patients. So the early biopsy as soon as possible, and of course, it has to be a decent size of the artery, 1.5 to 2 centimeters. Most of the vascular surgeon, they aim for less than 0.5, zero point 0.2, or zero point 0.3 plus minus. So it's very difficult. And of course, it's challenging for pathologists as well to get a good yield and to get a good sort of the reading of the biopsy report, biopsy slides, if you like. And then naturally, we should be thinking about some form of the imaging, for example, the chest x-ray, naturally, because we're looking at the mediastinum and so on, the ultrasound of in some of the fast track clinics, for example, what we used to run, I mean, we were involved in the study as well, where we were comparing the ultrasound of the temporal artery uh, to comparing it with the other sort of the features, for example, the biopsy. So in most of the centers, it's now considered that if you have a good ultrasonographer or your own self who is confident enough in doing the temporal artery biopsy, if somebody comes with the right symptoms and you have a gut feeling that you're talking about dealing with a patient of the giant cell arteritis, if you do the temporal artery ultrasound, and if the ultrasound is also suggestive, the typical what we call about the halo sign, if that is there, then you do not need to go and get a biopsy done, and you can be fairly confident that's what you're dealing with. And the other way around that can be helpful as well is that if somebody does not have the typical features and there is an anxiety that you could be overdiagnosing, then you can easily do the temporal artery ultrasound. If the ultrasound is negative, then you can be fairly confident that it's not the temporal artery ultrasound, temporal arteritis that you're dealing with. Another major challenge in dealing with the giant cell arteritis is to predict which are the patients who are going to have extra, for example, the vascular complication. the ischemic complications, in other words, for example, the stroke and loss of vision and so on. And there's a lot of literature on it that these are the patients for, in other words, you can say it's very challenging because these are the patients going to have low ESR and CRP. It's a very challenging. And of course, the patients are usually the male, younger age, and also having some other, the vascular sort of the risk factors, if you like. And the more important not to miss is that these patients are typically having low ESRs and CRP. Why this low ESR and CRP happens in these patients who have more tendency to develop ischemic complications. And there is some answers when we look at the axis, for example, the immune pathways. So there are two separate pathways. One, we know about the IL-17 axis, which is, we hear all this time about the spondyloarthritis, for example, the pathologies. And the other one is the interferon, gamma interferon through the Th1. So these are absolutely separate immune pathways. And the one that is involved IL-17, so the dendritic cells, they cause the induction of the IL-17 through Th17 cells. And this pathway is typically activated when somebody is going to have polymyalgia rheumatica symptoms, somebody is going to have acute phase reactants, for example, the typical constitutional symptoms. And these are the patients who usually respond to even low doses of steroids. Then there's a separate immune pathway where the dendritic cells through the Th1, they cause the production of gamma interferon. And these are the pathways which is typically affected in these patients who are going to have more ischemic complications. These are the patients who do not have that high acute phase reactants. They do not have very high the temperatures or constitutional symptoms. And further on, we can also get the same feeling of two separate immune pathways when we also look at, for example, the response to treatment. So the Th17 or the IL-6 pathways are the one which are going to respond to even lower moderate dose of steroids. And these patients are usually quite successful when we reduce down their steroids and they eventually come off steroids. But the other patients are the gamma interferon pathways. These are the patients, as I mentioned, going to have more ischemic complications and they respond to very high doses of steroids only. So there's a bit of sort of a dichotomy, if you like. There's a separate immune pathways when we're gonna deal with these ones. So there's also talking of the GCA mimics. So we also need to be very much mindful of the GCA mimics, not to overdiagnose and all this. For example, the sinusitis. So while dealing with giant cell arteritis, we also need to be mindful of GCA mimics. As I mentioned, because we're talking about the pain in the head and neck region, so there are going to be a lot of the mimics that we can deal with. For example, the migraine, the trigeminal neuralgia, for example. So there's a lot of other things, as I mentioned, about some simple ENT infections as well. So there is going to be dozens of the mimics, if you like, of the giant cell arteritis, which we need to be mindful because, as I mentioned, there is a significant morbidity associated with overdiagnosing because, of course, we're talking about high dose of steroids in an elderly patient. So these are the simple the steroids regimens that we use. For example, if somebody is going to have uncomplicated GCA, what I mean by the uncomplicated GCA, these are the patients who are going to have only cranial ischemic symptoms. So they don't have like sort of the cranial ischemic signs. These are the simple cranial symptoms. So in those patients, you can get away with the 30 to 40 milligrams for most of the patients. For example, even though somebody is going to have a jaw claudication, so 30 to 40 milligrams of prednisone can be enough. However, if somebody is having ischemic event, for example, the loss of vision or the stroke or something, then naturally you're talking about very high dose of steroids, not less than 1 milligram per kilogram. Rather, in most of the patients, you're talking about intravenous, the pulses of steroids. And naturally, we should also be considering about the proton pump inhibitors and the calcium and bisphosphonate. There has been a lot of debate about the low dose of aspirin and its benefit about preventing some ischemic events. There has been some original studies about it. The latest guidelines, they do not recommend this, but there has been some evidence to support that if you give aspirin to the patient with the giant cell arteritis, there is a relatively less ischemic event happening in these patients. Again, there is some again evidence as well that the aspirin do tend to reduce down the gamma interferons, which again affects the gamma interferons in terms of reducing down the ischemic events. So there is some rationale. Personally, if you ask me, I think it's a good practice that we should be giving some low dose of aspirin in these patients unless there is any major contraindication. Again, we are talking about the very gentle reduction of the steroids over a matter of 1.5 years plus minus. Again, it all depends. So the issues are that, as I mentioned, that 1.5 to 2 years of these patients will require the treatment for, and the cumulative dose is generally number of grams over 2 years. That is again, in number of the cohorts have come across with this, that you can look at more than 6.5 grams over 2 years that an elderly patient is being exposed to. Naturally, you're talking about significant morbidity associated with this. However, the relapses of the giant cell arteritis are extremely common, that the one quarter to nearly 2/3 of the patient are going to have some relapse during their disease course. And I think naturally it's true. I think more than 2/3 of the patient are going to have some relapse while we're going to reduce down their steroids. The number of, for example, the centers have tried some additional immunosuppression. For example, the methotrexate. Methotrexate is the most common drug studies. There has been one particular study which shows there was some effect, that the other study showed that probably the effect wasn't that much. However, the subsequent meta-analysis have demonstrated that there was actually some modest reduction when we combine the data of all these studies as got the relapse and some steroid exposure. So definitely there is some evidence there that it can provide some mild to modest effect as regards reducing down the steroid dose. Again, there have been other attempts as well to look for example, the Imuran and cyclophosphamide. The Imuran, the study wasn't that sort of convincing. The cyclophosphamide study did show that there was some rather good response as regards the steroid reduction. However, there was a significant treatment-related adverse events. So definitely the risk profile, the risk-benefit ratio, in other words, wasn't convincing to go for cyclophosphamide infusions. Although if you look at the anti-TNF, for example, although the TNF cytokines is overexpressed when you look at, for example, the blood, and also when we look at, for example, in the temporal artery biopsies in the vessels as well. But unfortunately, the 3 trials that have been looked for, the results have not been that convincing, unfortunately. The major breakthrough when we look at the biologics, for example, has been the discovery, of course, when they studied the IL-6 inhibitors in giant cell arteritis. Again, there is a very good evidence looking at the IL-6, for example, the cytokines in the blood and in the vessel wall. Again, there is a significant one. This is the New England Journal study, which proved the basis, or which served the basis, if you like, for the recognition, or the only drug approved so far for giant cell arteritis is this particular biologic, where they looked at the IL-6 inhibitor. In this particular slide, what you're looking for is the time to the first relapse. And in other words, the patient without any flare of giant cell arteritis. So the green bar and the purple bar are the patients who were on that IL-6 inhibitors. And you can see that around 80% of the patients who were in this particular biologic, they had no relapse when the patient were followed for 52 weeks. And again, the look at the other ones, for example, the yellow and the blue ones, what you can see, the steroids when they were tapered over a matter of 26 weeks, and the steroids when they tapered up to 52 weeks, that around only 20% of the patients, they had no relapse. So there was a significant difference when you look at the time to the first relapse with this particular biologic. Again, there is a very recent abstract presented when they looked at the patient, for example, should you be giving methotrexate along with IL-6 inhibitor to the patient with the giant cell arteritis? And it showed that if you're giving adjunctive methotrexate to these patients, did not provide any additional benefit, if you like. So I think IL-6 inhibitor on its own provide enough protection, if you like, and enough the disease remission, in other words. The follow-up, of course, is the most commonly what you look at is through the signs and symptoms. of the disease activity. And naturally, the inflammatory markers, getting the ESRs and the CRP routinely is also can be quite helpful. Imaging, not that much, but again, if somebody is already having, for example, the aortitis or other large vessel involvement in those patients, who of course having some 6 months yearly follow-up of the imaging, that can also provide some benefit as regards the follow-up. Naturally, we should be mindful of the side effect as regards osteoporosis and so on. The long-term complications, we should also be thinking as regards yearly chest x-rays and echocardiograms, for example, now and then, because as I mentioned, that the aortitis is not that common, but we do see now and then, and those patients having aortitis and then the mediastinal widening can be happening. So that's why yearly or maximum 2 yearly, there should be some chest x-ray or echocardiogram repeated in these patients. So let's look very briefly and very quickly about some of the myths and the clinical purpose, if you like, because there's a lot of sort of the myths people talk about when they talk of GCA. So one major thing is that the GCA never occurs before the age of 50 years. So this statement is remarkably robust and it's absolutely true. For example, the Mayo Clinic, the data of more than 1,400 biopsy-proven GCA patients, and out of those more than 1,400, there were only 2 patients whose age was less than 50. And there was very strong suspicions that these patients actually did not have giant cell arteritis, rather have some other form of systemic vasculitis. Again, if the temporal arteries, for example, on examination are normal, can you exclude GCA? For example, if somebody comes with a headache and you palpate the temporal arteries, and if the temporal arteries are normal on examination, can you exclude that this patient does not have GCA, and that particular patient does not require any further investigations, if you like? And this is unfortunately not right, because as I mentioned here is that 1/3 of the patients with the giant cell arteritis are gonna be having normal temporal artery examination, means no temporal artery tenderness or reduced pulsations or anything. Rather, they talk about that you could be lucky to find nodular thickened temporal arteries, because that would mean the longevity or the chronicity of the symptoms, rather than somebody is coming with a much shorter duration of symptoms. The other, for example, the common question is that the GCA symptoms, the most specific one is the jaw claudication, and this is true. And it's also important to understand that there could be a lot of people explain this in a different sort of wordings, if you like. For example, the facial pressure while talking, reluctance to eat meat because of the difficulty chewing. And this is also very important, because you do not have to have a big chunk or a thick sort of the meat to elicit jaw claudication. It's important thing to understand that the jaw claudication happens early, and again, it can happen with even a soft diet, if you like. There could also be difficulty speaking, and there could also be pain in the tongue. And this is one of the most specific clinical feature of giant cell arteritis, along with diplopia. So also, it's also mentioned that if somebody is having new unexplained pain located above the neck in a person who is more than 60 years old, should you suggest the possibility of GCA? And I think this is absolutely right. We should be considering this. For example, headache and jaw claudications are typical, but there could be pain over the nose, in the ears, along the jaw, in the throat, in the mouth, and over the occiput. So as I mentioned, unfortunately, there could be a lot of non-specific symptoms in these patients, and we should not be, of course, ignoring any of those ones. GCA can be a common cause of PUA. If you look at for example, the literature overall of the PUO, the GCA would count only about 2%. However, if you look at the elderly population, the GCA is a culprit in about 16% of the PUO cases. In one study, rather, they mentioned that the 15% of the GCA patient had fever prior to the diagnosis, and it was always been associated with very high acute phase reactants and also thrombocytosis. So why it only affects temporal arteries, or does it only affect temporal arteries? And that's why a lot of people quote this as temporal arteritis. So there's a misconception that probably it only affects the temporal arteries, and this is not right. As you mentioned, this is a large to medium vessel vasculitis. We call this temporal arteritis only because this is the most visible artery to examine and to biopsy. And that is the reason why a lot of times it's regarded as, considered as, or called as temporal arteritis. So another thing also is considered is that normal fundoscopy exclude the diagnosis of GCA. So for example, if somebody comes to you who has the headache and also some eye, for example, the blurring or having some eye symptoms, and if you do the fundoscope and the fundoscope is normal, can you exclude the diagnosis of GCA? It's not true. It all depends on what particular precise site in the temporal, in your optical artery around the track of the optical the artery is affected. As I mentioned here, is that fundoscopy can be absolutely normal in GCA patients, even who have lost their vision. So somebody has a GCA, has lost their vision, and if you're doing the fundoscope can be absolutely normal in certain patients. And as I mentioned earlier just now, that it is absolutely dictated by the precise site of the vascular lesion, which has led to the vision loss. And these are the 5 different pathways or the spots in the around the track which can be affected. For example, the most common one is the anterior ischemic optic neuropathy, where there's a vasculitic occlusion of the posterior ciliary arteries, which perfuse the neuroocular junction at the optic nerve head. And the other one is the posterior ischemic optic neuropathy. In these cases, the fundoscopy can be normal in the initial settings. The third one is the central retinal artery or the branch retinal artery occlusion, which happens in the temporal arteritis, which can also lead to naturally some vision loss, which happens in 20% of the GCA. There can also be the whole optic artery affected. Of course, the whole occlusion, that the entire eye is ischemic. And lastly, we should not be forgetting about the posterior circulation stroke, where there could also be the vision loss. And naturally, the fundoscopy is going to be normal in these patients. Another one is that how about that if there's an acute unilateral vision loss in an elderly individual, should you be always considering GCA? If you look at only a small minority of the patients, not like, because I know there's a lot of anxiety that if any elderly patient with a vision loss, people consider and start straight away on high dose of steroids. Only a small minority of the patient going to have a GCA. Most of the patient going to have what we call non-arthritic ischemic optic neuropathy, means these patients are typical vasculopath, and these are having some thromboembolic sort of the process of the phenomena leading to the acute vision loss. So vision loss does not necessarily rather mean that somebody is having GCA. Should you be referring all the patients who you consider to be having giant cell arteritis to ophthalmologists? I would personally say not really. It's only in those patients who are going to have some visual symptoms. These are the patients should be referred to an ophthalmologist. Otherwise, there is no particular benefit. How about the people talk about that if there is any delay in terms of getting the biopsy done, should you still be considering the biopsy? Because there's a lot of anxiety. I personally have seen referred the patient to vascular surgeons, and they refuse purely based on that the patient is already on steroids. That's actually true to a certain extent, but not fully. For example, if you look at the Mayo Clinic data, the diagnostic histopathological findings, they were still able to elicit, even there was 11 months delay even to get the biopsy. So even the good pathologists can be able to elicit some findings which we call atypical. So the typical ones are without, of course, the treatment, and then the biopsy specimens naturally can be altered with the therapy, but still there could be some features which can be helpful to a good pathologist to come up with the diagnosis to elicit the features of giant cell arteritis. So the preferred site is the anterior temporal artery, but unfortunately, most of the surgeons, they aim for common temporal artery because it's easy, it's a big one, it's a big chunk, easy to get. But it all depends, unfortunately, not the ease of getting the biopsy, but the more important is to find the true tenderness where there is a tenderness that the thickening is, and then to target that particular site, because we all know there's a lot of skip lesions in these patients with the giant cell arteritis. Another one, quite a lot of misconception about giant cell arteritis is that it does not affect CNS. We know that it predominantly or almost always affects the extracranial portions of the arteries. That's why they mentioned that probably the extracranial arteries, the moment they enter the dura, they lose their external elastic lamina. So that's why there's a less, but there is a lot to do that the patient still can have a lot of CNS involvement coming from the extracranial involvement at the same time. For example, this TIAs, vertigos, hearing loss, and the stroke because of the involvement of the vertebral arteries, although they are still the extradural. So still, it can affect the CNS. In simple words, I just show you here one of the cases. This was a 76 years old gentleman who came in with a 1 month history of progressive onset of the right facial paresthesia, dysarthria, gait ataxia, vertigo, and the left hemiparesis. So it was a very simple, straightforward, like a new onset of the stroke. He did have a lot of the vascular sort of the risk factors, for example, hypertension, hypercholesterolemia, smoking, and the coronary disease, and was taking a daily dose of aspirin already before coming to us. So there was a lot to blame just purely to the stroke coming from being a vasculopath. He did not have headache, and the temporal artery palpation was normal in this particular case. The only reason why we went about asking and looking for temporal artery palpation was because his ESRs and the acute phase reactants were all over the place. His ESR was more than 60. Otherwise, the routine blood work was normal. So he was considered to be having GCA. Again, he had the biopsy, and that's his particular biopsy of the temporal artery, which you can see is a complete occlusion of the temporal artery because of the giant cell arteritis, inflammatory cell infiltrates, as you can see, the multinuclear giant cells, and the intimal proliferation is so much, as I mentioned, that the whole intimal was blocked in this particular patient. So in this particular patient, the GCA led to a stroke in this patient. So the vertebro-basilar insufficiency is more common when we talk about the CNS manifestations of giant cell arteritis. As I mentioned, is known to affect the extracranial portion of the vertebral arteries and cause a neurological deficit in the vertebro-basilar circulation territories. And the delayed diagnosis, unfortunately, carries significantly high, not the morbidity, unfortunately, the mortality, because of course, it's not just a unilateral, there could be the bilateral involvement in these patients. So that's why, unfortunately, it carries a significantly high mortality. In Dublin, the center where I was working, so we used to have the stroke services. So every patient coming with either TIA or strokes would be dealt by a stroke team, a dedicated stroke team. And in those sort of, they have this a protocol that every patient with a stroke, they would get their acute inflammatory markers checked. And if there was unexplained acute phase reactants raised in any particular patient with a stroke, we used to be called in to look for any occult giant cell arteritis in these particular patients. So lastly, we should not be forgetting about the aortitis because we are talking about a systemic vasculitis, as I mentioned. So it is aorta, the aortitis is affected in 17% of the patients and can manifest as aortic aneurysms, aortic ruptures, aortic dissections, and a lot of other sort of the manifestations of the complications of the GCA. Aneurysms of the ascending thoracic aorta, it's very important to understand, happens 17 times more common among patients with the giant cell arteritis than the same age matched other patients. And again, the aneurysms of the abdominal aorta also happens 2.5 times more frequent among the patients with the giant cell arteritis. So aortitis is common enough when we talk the giant cell arteritis compared to the age-matched population. And so that is the reason why a lot of times there is recommended that at least once a year or at least once in 2 years, these patients should have their chest X-ray done to look for any mediastinal widening, for example, if there is a aortitis or the thoracic aortic aneurysm. Involvement of the primary branches of the aorta happens around 15%. So the aortitis happens, or the thoracic aorta, but the involvement of the primary branches of aorta happens in 15% of the cases. Hence, in our clinics in Dublin, we used to have every patient would get their blood pressure checked in the both arm to look for any occult manifestation of the involvement of the primary branches, for example, the subclavian and so on. I think that's the finish of my talk, and I'm open for any discussions or any questions.